Hi everyone, it's Malik Rassi here, and in this video we're going to go through knee arthroscopy. We're going to break it down into 5 main sections. The first 3 sections will cover the basic steps of the procedure itself, such as positioning the patient, inserting our portals, and looking around the knee. Then we'll go over some common mistakes and how to avoid them, and then finally look at examples of pathology that you're likely to come across when carrying out a knee arthroscopy. Let's start with positioning the patient. The main things to focus on here are the tourniquet and the side support. The tourniquet should be relatively high, and we've put isolation tape on it here to avoid it slipping down and to avoid any skin prep from tracking up underneath it. Positioning the side support here is key. The exact height of it will change depending on the patient, but generally around the junction of proximal and middle thirds of the thigh. Its purpose is to allow us to put valgus force on the knee to give us more room when accessing the medial compartment. What we have to make sure we're able to do is abduct the hip enough to hang the leg off the side of the bed, firstly to check patellar tracking, and secondly to access the notch. We also need to be able to apply a valgus force to the knee to give us more room when accessing the medial compartment, and the post here gives us the counter force to do that. If the post is too high, then it won't provide adequate support against which we can apply the valgus force on the knee. If the post is too low, then we won't be able to abduct the hip adequately to be able to perform the procedure. So here we are checking our position. We can abduct the leg just enough to be able to fit between it and the table, and the knee can flex comfortably off the side of the bed, which we're happy with. Finally, this is probably the best time to do your EUA. We're not going to go into much detail on it here, but you want to examine the medial and lateral collateral ligaments, as well as the ACL and PCL, with varus and valgus force, Lachman's anterior draw, and pivot shift tests. We'll start by prepping the foot. If you're lucky, someone in theatre can lift up the leg for you so you can get right round underneath the heel. And then if you grab the foot with the sterile stockinette, hand out those 2 swabs and get a fresh pair, which you can use to prep the rest of the leg. If you're not so fortunate, then if you prep the toes, you can grab them with the sterile stockinette and lift the foot up to be able to clean the rest of the heel. We'll roll the stockinette all the way up to the tourniquet, taking care not to compromise our sterility. And then we'll put our arthroscopy drape on. A little tip here, if we just pause the video, is on the underside of the drape, you can see there's a drawing of a person, and the head of this goes to the head of the patient, so you don't get it the wrong way around. The drape we're using here has channels to allow drainage of fluid, and so we're going to cut the end of one of those channels and connect it to some suction. We'll then cut a hole in the stockinette so we can actually get at the knee, and then finally, because we will be sitting down on a chair and moving the leg around, we generally use a sterile drape on the stool to reduce the risk of contamination. Let's just stop here for a minute and have a look at our theatre setup. It's relatively straightforward for an arthroscopy. The surgeon is sitting on the side of the leg that is being operated on. So here we've got a left leg, so the surgeon is sitting on the left hand side. The arthroscopy stack is on the opposite side, straight ahead, and the scrub nurse and their trays are generally at the foot of the bed. We're using a wheelie stool here, We mentioned earlier that we're going to need to put a valgus force on the knee. There will be a bit of moving around to do things like that, as we'll soon see, so you may find it easier if your seat is a bit more mobile to allow you to change your position more comfortably. Right, let's sit down and get ready to put our first portal in. It will be the anterolateral portal, and this one is generally used for the arthroscope to look around the knee. We want to flex the knee to 90 degrees, and you can easily keep it in this position by resting the foot on the inside of your thigh, in this case, our left thigh. Before we do anything, we'll just consider our landmarks for the incision. We have our patella tendon, and our tibial tubercle. If you feel for the lateral border of the patella tendon and for the joint line, between the two you should feel a soft spot, which we've drawn in red here. That's going to be where we place our incision. Either horizontal or vertical incisions are fine. Horizontal portals are more cosmetic, but if you're too high or low, it can be difficult to correct. A vertical incision is more forgiving in that respect, but there is a risk of damaging the anterior horn of the lateral meniscus if you're too low. We're going to be using horizontal incisions, so we're going to make an incision about 1 centimeter long, just lateral to the lateral border of the patella tendon, at the level of the distal pole of the patella. Let's make our incision then. We'll reorientate ourselves, feel the patella tendon, feel the distal pole of the patella, and get our thumb right into that soft spot. From our skin incision down to the capsule, we're going to use controlled, gentle strokes, feeling the resistance of the tissues to the blade. Once that resistance disappears, we know we're inside the joint. 2 things to mention here. Firstly, keep the blade pointed laterally to avoid inadvertent damage to the patella tendon. Secondly, we're aiming for the notch. This has 2 benefits. Firstly, it reduces the risk of damaging the articular cartilage on the lateral femoral condyle. And secondly, as our incision effectively creates a channel through the tissues through which we're going to insert our instruments, if our incision and therefore channel was in a true AP direction, we may struggle with resistance from the tissues when trying to angle the camera round, such as when trying to get into the medial compartment. Get the trocar and insert it in the same direction, aiming towards the notch. If you're struggling to get it in, your skin incision may not be long enough, or you may not have actually made it through the capsule with your knife. Once you're in, extend the leg and rest it flat on the table. Push the trocar in further, aiming for the space between the patella and the trochlea, and keeping the trocar horizontal to avoid damaging the cartilage of either structure by excessive angulation up or down. Once the trocar's in, connect your camera and light source, having first checked to make sure that a white balance has been done, and then connect your water supply. This can be a 3-litre bag or a 1-litre bag, depending on what you plan on doing during the procedure. You may find that there's either a lot of debris or synovial fluid that's affecting your vision, so what you can do is irrigate the knee by firstly letting it fill up, then turning off the water supply and letting it drain out of the other portal on your trocar, and then remembering to close that portal and reopen the water supply, and you can do this several times. This is where our arthroscopy drape comes in quite handy, but only if you've remembered to connect the suction to the drainage port that we cut off earlier. Before we get started with moving around, we should probably make sure that we fully understand how the camera and light source work. This is our camera, and this is our light source, and both of them can rotate around, which can be both very useful and very confusing. The camera controls your horizon, i.e. which way is up and which way is down. As you can see, turning the camera around 90 degrees to the left and to the right rotates the whole view by the same amount. The light source is a little bit different. A 30-degree scope is generally the standard for knee arthroscopy, which means that the view from the end of the scope is not directly ahead of you, like looking down a telescope for example, but angled by 30 degrees in a certain direction. That direction is generally indicated by a notch on the monitor, but if you think of it as an arrow, that may be more useful, or alternatively by the direction that the light source is pointing. And here we're looking to the right. By rotating the light source, we can look up, we can look down, and we can look to the left. Here we are again looking down and then up at the patella. During this procedure, we're going to need to manipulate both of these to be able to view all the required structures, and losing track of them is one of the easiest ways to become disorientated and get stuck. So we're going to keep coming back to it throughout the video. Let's start by setting a default position of the camera and the light source, which is the position we just started with earlier. The camera buttons, if we imagine that to be 12 o'clock, are pointing directly up so that our horizon is horizontal, and the light source is pointing round to the right. We can see here why that makes sense. Because our lateral portal is our camera portal, most of the structures in the knee are either ahead of us or on the right. Now you may have spotted that we're completely missing the anterior horn of the medial meniscus, and to a lesser extent the posterior horn of the lateral meniscus. So we can rotate the light source around to look to the left, as we can see here. Now it does get a little bit more complicated than that, but we'll keep this default setting in our minds, as it'll definitely make things easier. The other thing we're going to briefly cover here is how to hold the scope. In the picture here, you can see that we're holding the trocar and light source securely, whilst using our extended fingers to brace ourselves against the skin. This helps us hold the scope securely, and if we move the knee at all, we can avoid the scope accidentally slipping in further and damaging the cartilage, or moving the other way and sliding out. We can also make very controlled movements and adjustments to the camera, as we're always referencing our movements to the front of the knee. The downsides are that you can't reach the buttons to take a picture with the same hand, and that the camera itself isn't secured, so if you aren't careful, it can rotate around and disorientate you. It's also a bit cumbersome if you're just starting, so you may find it easier to hold the camera itself, as we can see here, where you have a bit more control over the camera rotation, and it is a little bit easier to move the scope around. Now we have our camera in, but no tools. At this stage, all we can do is look around. So these are the 5 things, in order, that we're going to examine on our initial inspection. For this part of the procedure, we're going to keep the leg extended on the table as we go through this list. We will start with the patella, and for that we will turn our light source round so that we're looking up, but keep the camera horizontal. We're looking at the articular surface and assessing for any damage or wear on the medial or lateral patellar facets. It's worth looking up the outer bridge classification of cartilage breakdown if you don't know it already. Then we look right to assess the trochlear cartilage and slowly flex the knee off the side of the bed to look at patellar tracking. The patella should sit centrally, but here you might have spotted that it is tracking slightly laterally. Put the leg back on the bed and go round to the lateral gutter. It's worth remembering that the lateral femoral condyle projects higher than the medial side, so if you have trouble getting over, instead of forcing it, you can lift the scope over, as we're doing here. As you go, check for a plica and look down to make sure you don't miss any loose bodies, before going back round and doing the same on the medial gutter. Let's pause here for just a second. We've completed our initial inspection, so let's proceed by entering the medial compartment and making our anteromedial portal, which is going to be our primary instrumentation portal. We can see that because we finished our initial inspection with the medial gutter, we're almost there. You can see the medial femoral condyle and a structure that could be tibia or medial meniscus. To do this, Keep the camera in your right hand focused on that femoral condyle. With your left hand, pick up the foot and move it round so that it's resting on your right hip. If you were scoping the right knee, then you would do the same thing but the opposite way round. You can see the position here. By gently leaning over or pushing your hip to the right, you can apply a valgus force, as we discussed at the start of the video, to open up that medial compartment. We're going to make our anteromedial portal under direct vision, so let's look to the left now. Start by inserting a white needle to check your position on screen. Your portals should be roughly symmetrical, but at this stage it can be difficult to feel your landmarks. If you think of the medial meniscus as a compass, with the north and south at the PCL and ACL respectively, your position should be at around southwest, as shown on the diagram. If you're happy with your position, get the knife ready, keep your eyes on that needle, and ask your scrub nurse to remove it and make your incision. Again, always keep looking with your camera to make sure you're cutting in the right place and not damaging the meniscus or articular cartilage by going too deep. And like the lateral side, aim for the notch. Once you're in, you can use something blunt like the obturator for the trocar or an artery clip to stretch out the channel and make it easier to get your instruments in and out. This process can be a bit tricky, so let's look at it again on a different patient. With the leg extended and resting on our outside hip, with the scope, keep looking around to the left, focusing on the medial wall. Get our white needle and insert it around 45 degrees. Then keeping our eyes on the skin at the point where we inserted the needle, get the scrub nurse to remove the needle and then make our incision. Keep the blade directed around 45 degrees towards the notch and make sure the blade is always facing medially away from the patellar tendon. After making the anteromedial portal, get your probe and examine the medial compartment. We're in our default camera position with the camera horizontal in the same plane as the tibial plateau and the scope looking to the right. We can see here the medial meniscus, the medial femoral condyle and the medial tibial condyle. Run the probe underneath and on the surface of the meniscus, then hook it over the top and then bottom and gently pull to check for any tears. Gently feel the articular surfaces to assess for softening or to investigate any fissures or osteochondral defects. There's something suspicious here that looks like an osteochondral defect, and we're going to want to know if this is stable or unstable by gently probing the edges and seeing if it's loose. We will then move on to the notch to check the ACL. At this stage, you can either rest the leg in your lap with the knee flexed as we have here, or hanging off the side of the bed. It can be quite common to get synovium or fat pad obstructing our vision, so once you have a bit more experience, you can shave it away. that it's critical that you do this under direct vision. Shaving too far anteriorly risks damaging the patellar tendon, too far posteriorly risks the ACL. You should also standardize with your scrub nurse the way the shaver is put together. Here, the teeth of the shaver faces the opposite direction to the buttons, so we always know which direction our shaver is pointed. Get your probe behind the ACL and assess its integrity by firmly tugging on it. Here, it's intact. We need to move to the lateral compartment now. We're going to need to put the leg into a figure of 4 position, so we need to do 2 things to make our lives easier and to protect the cartilage. Firstly, we're going to park the probe in the space between the ACL and lateral femoral condyle. It sits here quite comfortably and doesn't risk damaging the articular surfaces. It also avoids any difficulties in reinserting it once the position of the knee changes and the soft tissues move around our portals. To avoid the scope damaging the cartilage, we keep the scope and our attention focused on the lateral joint line, and with our left hand again we grab the foot and bring it over on top of the opposite leg in a figure of 4 position. With bigger legs or stiffer knees, you may need your scrub nurse to hold it there to stop it slipping off. You may have noticed that our orientation has changed and the joint line on screen has rotated around. We're going to rotate the camera into a new position now by rotating it around until the joint line on screen is horizontal. You've probably figured out by this stage that what we're trying to achieve with the camera positioning is to keep the horizon of the camera parallel to the joint line or tibial plateau. So the buttons are always pointing perpendicular to the horizon and therefore in line with the tibia. You may find that to be an easier way to reference the camera position and orientation. It is also worth considering that to some extent we are sacrificing the real life orientation of the knee to give us a horizontal image. Here the joint line is actually vertical, though we are viewing it as horizontal. Most people find it easier to keep the orientation of the video horizontal as we have it here, but if you find that you're struggling to triangulate your instruments with this method, then by all means rotate the camera around so the orientation of the picture on screen matches that of the knee in real life. Once in the lateral compartment, again probe the articular surfaces and the meniscus to check for tears. Here we're rotating the camera to look down and inspect the anterior horn of the lateral meniscus. Let's go over that process of getting into the lateral compartment again. Instead of the fat pad we saw previously, we see an anterior plica or ligamentum mucosum. Instead of shaving it, we can choose to move around it, either anteriorly or posteriorly. Here, we are taking the arthroscope around the front by using the probe to pull down on the plica and create the space for us to pass. And then we'll park our probe into that gap between the ACL and the lateral femoral condyle, grab the foot with our hand, and whilst keeping an eye on that articular surface so we don't jog it with the scope, we'll bring the leg round into a figure of 4. There's a lot to take in, so we've got a table here that runs through all the different positions of the leg and the scope and camera and light source for all the steps of the procedure that we've covered so far. You can pause the video and go through it at your own pace. One of the most important things to get right is the height of your portals. You may find that you struggle with certain aspects of the operation, so let's try and go through a few scenarios where it's quite easy to get stuck. One of the most important things to get right is the height of your portals. If we look at the picture on the left here, the portal is quite high. In this scenario, you will struggle to adequately visualize structures such as the posterior horn of the medial meniscus, as the femoral condyles are in the way. In the middle picture, the portal is too low. In addition to risking damaging the meniscus, it can be a struggle to move around the knee as your scope is always hinging on that anterior lip of the tibia. The final picture we can see has the correct height portal, and so we can easily get the scope in without pressing up against the femoral condyle or down against the tibial plateau. You may find that you struggle to get your instruments in and out of the portals, and it feels as though they're always catching on soft tissue before you can get them into the joint. This can be because of one of two things generally. Either your portals aren't big enough, as is commonly the case, or you're trying to put them in at a different angle than you made your portals. So if, as we've suggested, you've made your portals aiming for the notch, always try and put your instruments in that direction. This is what we mean by portal size. Despite your skin incision being adequate, if you keep the blade relatively still until you breach the capsule, the size of the opening in the capsule is actually quite small, only the width of the blade. It's therefore important to make sure that you move the blade enough to be able to get an adequate sized hole interiorly as well as exteriorly. You may find that you struggle to find your instruments when inside the knee, for example when trying to put the tip of your probe in front of the camera. If you imagine the arthroscope and instrument, in this case the probe, are two sides of a triangle, getting those two sides to meet at a point is called triangulation. It can be a struggle for several reasons, not least due to the fact that you're taking something that's 3D and displaying it on a two-dimensional monitor. If you're struggling to find your probe entirely, one tip is to try and touch the arthroscope with your probe at any point along the scope. You may be doing that unintentionally already. Once you feel that metallic contact, gently slide the probe down along the scope until you reach the visual end. It's worth taking a second before you get to the end to identify if you're sliding along the top or bottom of the scope. Another technique, which also helps if you're having difficulty moving your instruments relative to the camera image you're seeing, is to reduce the angle between the two, or try to make them more parallel as opposed to triangular. The animation here is a bit exaggerated, but demonstrates the point. Also, remember in which direction you're looking. It may be that you've got everything in the right place, but you can't see your probe because you're looking off in the wrong direction. If you get into a situation like this where you can't see anything or there's too much blood, there are a few things you need to check. First of all, make sure that your water supply is connected and the tap is open. Secondly, make sure that the pressure is high enough. So if you're using a pump, make sure it's pumping at a high enough rate, or if you're just using a saline bag, you can raise it up on the drip stand or whatever you're using to increase the pressure that way. Check the camera to make sure that it's focused correctly. The last thing it could be is a tourniquet issue. Either the tourniquet is not on, or not at high enough pressure, or it could be functioning as a venous tourniquet, and actually it's just causing venous congestion, which is why you're getting a lot of the bleeding. That can happen if the tourniquet slips down the leg, so as we discussed at the start, we use tape to try and keep it in position. The last topic we're going to cover is getting to the posterior horn of the medial meniscus. In some knees it may not be an issue, but if you're struggling, there are three things that you need to do. Valgus force, as we've been doing to get to the medial compartment, external rotation of the tibia, which brings the medial compartment forward in relation to the femur, therefore bringing the posterior horn anteriorly, and slight flexion of the knee. This is where positioning yourself as a surgeon as well as the patient makes all the difference. You can manipulate the leg with your body to a certain extent, leaving your hands free. Leaning on or pushing out with your hip on the foot can provide some external rotation of the tibia. Flexing the knee can be achieved by adjusting the operating table height or by moving your seat towards the patient. The last thing we're going to look at is some pathology examples. Some of it we've seen already, others may be new. Starting in the lateral compartment, here we can see a longitudinal tear in the lateral meniscus. We will use the probe to determine the extent of the tear. Is there a radial component? Does the tear extend into the periphery, or is it full thickness down to the inferior surface? This tear is in the white on white or avascular zone. We cannot repair it, so we will need to debride it. For that, we'll first use the punch. And then the shaver to debride it down to a stable and smooth edge. We can see something in the lateral compartment obstructing our view. If we probe it, we can see that it's actually the lateral meniscus. This is a bucket handle tear which is flipped out into the lateral compartment. This can be quite complicated, but without going into too much detail, we're repairing this one using intra-articular sutures. It might look like there's a peripheral tear here, but there isn't. What we've done is simply put our probe into the popliteal hiatus and we're pulling on that. Here we can see an osteochondral defect. As we mentioned earlier in the video, we need to use our probe to identify the margins and assess whether it's stable or unstable. Here we're repairing the fragment using osteochondral darts. Another lesion of the medial femoral condyle here. However, this is just a chondral lesion. We can probe it, but see that it doesn't go down to bone. If it did, we might consider something like a microfracture. However, in this case, we will simply debride the edges to make it smooth, first using the shaver and then the arthro wand. In this case, we can see more generalized features of osteoarthritis. There is softening and fibrillation of both the femoral and tibial articular surfaces, and we can see some fraying and degeneration of the medial meniscus. Right, that's us done. I hope it was useful, and thanks for watching.